of more than or equal to 20 breaths per minute, or a PaCO2 of less than or equal to 32 millimeters mercury, or mechanical ventilation, or a white blood cell count of more than or equal to 12,000 or less than or equal to 4,000 or more than or equal to 10% band form. So if there is the presence of two of this, so with we can define that the patient is having SIRS. So if there is an identifiable source of infection plus SIRS, so the patient is in sepsis. So if there is sepsis or dysfunction, we can now classify the patient as having severe sepsis. So by organ dysfunction, the patient can have acute kidney injury or neurologic manifestations, encephalopathy, or pulmonary manifestations, tory distress plus sepsis. So the patient as going into severe sepsis. If the patient already has cardiovascular collapse requiring vasopressor support, so the BP is low, below 80, systolic, 80 or below, requiring vasopressor support in the form of your inotropes. So in septic shock, we use norepinephrine. So in the setting of a septic patient, so we can now classify that he or she is in septic shock. So this is a must know. So this is a table lifted from Schwartz depicting the SIRS and CARS. So SIRS is systemic inflammatory response syndrome. So it is a spectrum going into CARS, your compensatory anti-inflammatory response syndrome. So when there is an insult, so say post-operatively, the patient should have a balance, should strike a balance between SIRS and CARS, so that the patient can recover without any adverse outcomes. So if the patient goes into more of SIRS, so the patient can have multi-organ dysfunction. So also if more of CARS, multi-organ dysfunction. So we would always want the patient to be maintained in between SIRS and CARS so that the patient can fully recover. So just like the principle of homeostasis. So in the presence of cellular injury, the body produces your DAMPs, the DAMP molecules. Examples are here in this table, the HMGB1. Then they bind to the putative receptors, your toll-like receptors, your interleukins. So an inflammation is then started, so which will lead to the release of your cytokines and chemokines from the macrophages or monocytes and dendritic cells, neutrophilic activation and chemotaxis, then alterations in epithelial barrier function, leading to increased capillary permeability, increased procoagulant activity on platelet surfaces, among others. Next is the CNS regulation of inflammation in response to injury. So also the CNS has a role during injury. So there is a feedback mechanism. So when the body detects a cellular injury or cellular insult, the nerve impulses will modulate cells in the brainstem, specifically at the dorsal motor nucleus of the vagus, from which your efferent parasympathetic impulses originate. So axons from these cells, which comprise the visceromotor component of the vagus nerve, form the inflammatory reflex that will feed back to the periphery to regulate your inflammatory signaling events. So any cellular insult will be sensed by the vagus nerve, so transported to the visceromotor component of the vagus nerve. so which comprises your inflammatory reflex. Then the CNS will then produce your responses to signal the body to release more chemokines through the sympathetic system. So there is a circuit. We also have the hypothalamic pituitary axis. No? So in response to the DAMPs and their receptors, the tumor necrosis factor, interleukins, interferon, corticotropin-releasing hormone is released from the hypothalamus, thereby also stimulating ACTH secretion from the pituitary gland in response to cellular injury. Then glucocorticoids are produced from the adrenal cortex, which will counteract the inflammatory response. So that's why we give glucocorticoids in patients in sepsis or severe sepsis that is unresponsive to hydration and antibiotics, because they will counteract the inflammatory response, especially when the body is overwhelmed. During states of cellular injury, like in inflammation or sepsis, there is what we call a relative adrenal insufficiency. So the adrenal gland cannot mount an effective cortisol response to match the degree of injury. That's why we give supplemental steroids in the form of hydrocortisone in patients on septic shock. So there will be hypoglycemia from decreased gluconeogenesis, hyponatremia from impaired renal tubular sodium resorption, and hyperkalemia from diminished kaliuresis. So rigorous testing to establish diagnosis includes monitoring of the basal and ACTH stimulated cortisol levels, both of which are low during states of adrenal insufficiency. And the treatment will include low-dose steroid supplementation. So we also have other factors like the growth hormone, insulin-like growth factor, then GHRELIN. So the growth hormone, insulin-like growth factor 1, they promote protein synthesis and insulin resistance and enhance the mobilization of fat stores in the body during inflammatory states. Then growth hormone also enhances phagocytic activity of the immunocytes. So the catabolic state that follows severe injury, so it has been linked to the suppression of your growth hormone inhibiting growth factor and the IGF-BP axis. So as critical illness is associated with decreased levels of growth hormone and IGF-1. Then GHRELIN promotes protein synthesis and insulin resistance and enhances the mobilization also of fat stores. High GHRELIN levels in inflammatory states were a positive predictor of intensive care unit survival in septic patients. So GHRELIN is, I think, released by the epsilon cells of your pancreas. Next, the role of catecholamines in post-injury inflammation. So catecholamines, your epinephrine, dopamine, results in increased heart rate, myocardial contractility, conduction velocity, and blood pressure. They also increase cellular metabolism, hyperglycemia, and promotes the release of your inflammatory cytokines and chemokines. So they also induce glycogenolysis, lipolysis, thereby increasing your stores, your energy stores, increasing lactate production, independent of the available oxygen. So the process is termed aerobic glycolysis. So in cellular stress responses, there are also other processes involved. So we have their byproducts, their active oxygen species, heat shock response. We have autophagy, which is automated cell death, apoptosis, and necroptosis. Next, we go to surgical metabolism. So during fasting, metabolism during fasting. So this is also a table lifted from Schwartz. Fluid utilization, depicting fluid utilization in a 70 kilogram man during short-term fasting with an approximate BEE of 1.8 kcal. So during starvation, muscle proteins and fat stores, they provide fuel for the host. No? So muscle proteins are converted to amino acids, which are then used for gluconeogenesis, as well as your glycerol and fatty acids from your fat stores and triglycerides. So gluconeogenesis, from the term itself, will be used for glucose production, which will provide energy for the brain, the RBCs, WBCs, nerves, kidneys, and the muscles. So fatty acid will be oxidized to produce ketones, which will be used also by the heart, kidneys, and muscles, especially during prolonged fasting. So approximately 22 to 25 kilocalories per kilogram per day are drawn from your carbohydrates, lipids, and protein sources. So in states of severe stress, such as those in patients with burn injuries, this can increase. The requirement can increase to 40 kilocalories per kilogram per day. Okay. So in prolonged starvation, systemic proteolysis is reduced to approximately 20 grams per day, and urinary nitrogen excretion stabilizes at levels of 2 to 5 grams per day. So there is recycling of peripheral lactate and pyruvate for hepatic gluconeogenesis using the process called the Cori cycle. Alanine within skeletal muscle can also be used as a precursor for hepatic gluconeogenesis during prolonged starvation. So in long-term fasting, as mentioned earlier, ketone bodies already become the important fuel source for brain, specifically starting after 2 days of fasting and gradually becoming the principal source of energy at day 24. So from 2 days up to day 24. Metabolism after injury. The magnitude of metabolic expenditure appears to be directly proportional to the severity of insult. So as we see here on the table, septic patients or burn patients, they have far greater metabolic expenditure compared to patients undergoing elective surgery. Next is lipid metabolism after injury. Lipid metabolism minimizes proteolysis, and they influence the structural integrity of cell membranes as well as immune response during systemic inflammation. They become the predominant energy source during critical illness and after injury, and 1 gram of lipid can provide the body with 90 kilocalories of energy. So this is a diagram illustrating lipolysis and fatty acid oxidation. During periods of trauma or sepsis, there is a suppression of the lipoprotein lipase activity in both the adipose tissue and muscle, presumably mediated by the tumor necrosis factor. Next is lipid metabolism. So the liver cells, the hepatocytes, they use free fatty acids during stress states. They synthesize TAG during fed states. So tissue utilization of TAG via lipoprotein lipase happens And during trauma, there is suppression also of your lipoprotein activity as mentioned earlier. This is an illustration of lipid metabolism. So with the help of your catecholamines, ACTH, thyroid hormone, and growth hormone, there will be activation of your triglyceride lipase or your lipoprotein lipase. So through that, there will be transporting of your free fatty acids via albumin, which will commence now your beta oxidation to provide the body with more energy. So during stressful states like in trauma, severe shock, and sepsis, there will be attenuation of your ketogenesis by increasing insulin levels and causing rapid tissue oxidation of your free fatty acid. So the rate of ketogenesis will be inversely related to the severity of trauma. Next are your carbohydrates. So 1 gram of your carbohydrate can give you 4 kilocalories of energy. In septic and trauma patients, provision of exogenous glucose has never been shown to fully suppress amino acid degradation or gluconeogenesis. Then insulin administration will reduce the rate of protein catabolism in periods of stress. So through the help of your catecholamines and glucagon, there will be hepatic gluconeogenesis, which will give now the glucose needed for functioning of your nervous system, healing of their wounds, and energy for your erythrocytes. 1 gram of protein will give you 4 kilocalories as mentioned earlier. So after injury, there will be proteolysis, 30% nitrogen excretion of the body, and 1.5% loss of lean body mass. So without nutritional supplementation, the body will lose approximately 1/4 to 1/3 of her lean body mass per day. So there will be changes in protein catabolism and synthesis that will correspond to the severity and duration of injury. Which leads us to the nutrition in surgical patients. So as mentioned earlier, the nitrogen excretion and injury severity is directly related to the level of injury, such as in patients with major burns or septic shock. So the goal of nutritional support is to meet the energy requirements for essential metabolic processes and tissue repair. So there is what we call the Harris-Benedict equation, which will help us in computing the basal energy expenditure for men or women. So this is the formula. So nice to know, Lainey. So this is also an important table. No? So in patients with normal or moderate malnutrition, the required BEE is only at 25 to 30. And the grams of protein per kilogram per day is 1. However, in states of severe stress, in burns, this can go up to 30 to 35 or even up to 40 for burns. And the grams of protein per kilogram per day can increase up to 2.5. So this is important so that we can measure the nutritional requirement of the patient daily. As mentioned here, the non-protein to calorie and nitrogen ratio should be maintained at 150:1, and 0.25 to 0.35 grams of nitrogen per kilogram of body weight should be provided daily. However, it should also be noted that we should not overfeed the patient, because if we overfeed the patient, it can lead to clinical deterioration due to increased oxygen consumption, carbon dioxide production, prolonged need for ventilatory support, suppression of your leukocyte function, and also increase in the glucose level, hyperglycemia, and increased risk for infection because of increase in your glucocorticoids. So among all modes of nutrition, we always advocate for the enteral nutrition because enteral nutrition, so via mouth, so feeding the patient using the gut. It has the advantage of being at a lower cost with no need for vascular access. However, in the setting of GI tract, if we do not use the GI tract, there will be diminished levels of IgA, bacterial overgrowth in the gut, which can lead to altered mucosal defenses. In the setting of early enteral nutrition, there will be better small intestinal carbohydrate absorption, shorter duration of mechanical ventilation, and shorter time in the intensive care unit. So for us surgeons, we always advocate for enteral nutrition. So it is also a part of the ERAS protocol or the enhanced recovery after surgery. So post-operative patients, even if we do bowel anastomosis, we always advocate for the use of the gut or enteral nutrition for our patients. So there is what we call caloric restriction or hypocaloric enteral nutrition. So as mentioned earlier, we should not overfeed the patient because this results to adverse outcomes, so increase in your glucocorticoids, hyperglycemia. So caloric restriction, attributing the benefits to improved cellular function in terms of insulin sensitivity, mitochondrial free radical generation, plasma membrane redox system. So the caloric goal is only to give at least 60 to 70% of the needed enteral nutrition compared to giving a full 90 to 100%. So there are feeding formulas that are considered to be gastrointestinal tolerance promoting, anti-inflammatory, immune modulating, organ supportive, and standard in the giving of enteral nutrition. So the type of enteral solutions to be used will depend on the extent of organ dysfunction and the functional status of the GI tract. So types of enteral formulas include your low residue, isotonic solutions, immune enhancing, calorie dense formulas, high protein formulas, elemental, and specific for renal, hepatic, and pulmonary failure. So we have different types of access for enteral nutrition. So if the patient cannot feed by mouth, we can use nasogastric tube, PEG. So this is a table from Schwartz depicting the different options for enteral feeding access. So we can give it via nasogastric tube, which has the disadvantage of only being used short term. So we have to replace the tube every now and then. There's also a risk for aspiration and nasopharyngeal trauma with frequent dislodgement. So patients also can use nasoduodenal or nasojejunal tube, especially if you want to bypass, say, for example, the pancreas during pancreatic injury, but we want to start feeding the patient. So we can use nasojejunal tubes. So in patients also, for example, with chronically debilitated patients, mga neurological patients, post-stroke, frail elderly patients who cannot tolerate feeding with the risk of aspiration, we can insert a PEG tube for feeding. Also for surgical gastrostomy, especially for patients who have esophageal masses. We can also use fluoroscopic gastrostomy, PEG jejunal tube, jejunostomy feeding if gastric masses are too big. You can also give fluoroscopic jejunostomy. No, but we don't do this often. So in clinical practice, we use nasogastric, nasojejunal, PEG, gastrostomy, or jejunostomy tubes to feed our patients enterally. Next is your parenteral nutrition. So if the patient cannot tolerate enteral feeding, or if enteral feeding is insufficient to maintain the daily energy requirements of the patient, we give parenteral nutrition, which is continuous infusion of a hyperosmolar solution containing carbohydrates, protein, fat, and other necessary nutrients through an indwelling catheter inserted into the superior vena cava. So it is important to note that when we give parenteral nutrition, especially for patients more than 2 weeks, it is always important to give it via a central line or central access. If less than 2 weeks, we can give the parenteral nutrition through a peripheral line. The indications include malnutrition, sepsis, surgical or traumatic injury, and if the use of a gastrointestinal tract feeding is not possible. So this is a table depicting the incidence of septic morbidity in parenterally and enterally fed trauma patients. So as we can see, parenterally fed patients really have a significant higher complication rate compared to the enterally fed patients. So it is really advocated that we give enteral nutrition whenever possible. So when is it indicated? So indications for parenteral nutrition for newborn infants with catastrophic GI anomalies, those who fail to thrive due to GI insufficiency, patients with short bowel injury, secondary to massive small bowel resection, especially for patients with less than or equal to 60 centimeters of small bowel post-resection. So they will be TPN dependent. Those with fistulas, so diba, we want to seal off the fistulas, so we do not give enteral feeding muna, especially for those with enteroenteric, enterocolic, enterovesical, enteroatmospheric, high output fistulas. Those with inflammatory bowel disease, with risk of rupture, so we give TPN, especially with those impaired absorption. So when is it contraindicated? So we do not start TPN, especially if patients are hemodynamically unstable with metabolic derangements. We always correct the hemodynamic instability and the metabolic derangements prior to giving parenteral nutrition. Also, if the GI tract feeding is feasible, so why not give via enteral feeding? Those with good nutritional status, infants with less than 8 centimeters of small bowel, patients who are irreversibly decerebrate or otherwise dehumanized. So there's no point in giving TPN. So as mentioned earlier, it should be accessed via a large diameter vein to deliver the entire nutritional requirement. And we give dextrose dextrose is also incorporated in TPN. However, in patients with TPN, it is important to know that we should give supplemental vitamin K. So wala sa slide, but it's important to give supplemental vitamin K since parenteral formulas do not have vitamin K. Also the essential minerals and vitamin K. So we have, as mentioned earlier, for those less than 2 weeks, we give peripheral parenteral nutrition. So this has a lower osmolarity compared to those that are given centrally with reduced levels of dextrose and protein. Adi ngayon. Vitamin K should be supplemented on a weekly basis. Also, essential fatty acid and your essential minerals like zinc, copper, chromium. So we should always supplement this. It is not total or complete parenteral nutrition if we do not give vitamin K and your essential fatty acids and minerals. So we draw electrolytes every 2 or 3 days thereafter and monitor our BUN levels of liver function indicators and blood counts. No? So it's important to note whether the patient also has CRIBC or catheter-related bloodstream infection from access for parenteral nutrition. That's why we should do our blood counts. Tapos we also should monitor our electrolyte levels since we are not giving enteral nutrition and this might affect the levels of electrolytes in the body. So this was mentioned earlier, no? The complications, your catheter-related or catheter-associated bloodstream infection, pneumothorax, hemothorax, hydrothorax, subclavian artery injury, thoracic duct injury from placement of your central line, air embolism, arrhythmia, catheter embolism, and cardiac perforation with tamponade. The metabolic complications include glucose intolerance, hypokalemia, cholestasis, and gallstone formation. Kasi patients receiving prolonged TPN really are prone to cholestasis. And lastly, since we do not use the GIP, they result in intestinal atrophy. So that ends my lecture. Thank you.
Thank you, Doc.
Okay. Since this is a short lecture, so I expect na lang that everybody will read the chapter on SRI and metabolic support. And then we just highlighted the important points. It's a very long chapter. You don't need to memorize the table. Only the commonly asked, frequently asked questions, no? Especially among the interleukins, which among those are pro or anti-inflammatory. So just refer to the tables as Schwartz. Those are repeatedly asked during the exam. The table on SEERS, the difference between enteral and parenteral nutrition, access or modes, feeding access, the energy use during prolonged fasting, the processes involved. Yun. So that's all. Thank you for listening. Happy Sunday. Mag-attend din.
Doc, ma-screenshot lang po kami for attendance.
Sige, ano yan?
Okay. I will be taking the screenshot now. Sige, first page, smile. Second page. Third page. Okay, done na. Thank you. Thank you,
Thank
Doc.
you.
Thank you, Doc.
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 Yo, present, Doc. To be present.
End ko na lahat meeting, guys.